Yeah. Good evening, everyone. We welcome you all to OrthoTV in association with ZEISS. This is the symposium of significance of magnification and illumination in spine surgery. And to introduce today's speakers, I hand over to our program coordinator, Dr. Neeraj Vasavada. Over to you.
Thank you, Neeraj. Good evening, friends. So, being an orthopedic surgeons, we always have probably looked as a very fancy equipment towards surgical microscope. But when you enter or foray into the field of spine surgery, I think, that is something which is unavoidable tool, which you will have to keep with you in your OT while you're operating on the spine. So why it is so? So we have a panel of very eminent speakers with us. So we have gathered 4 orthopedic surgeons, including myself, and 1 neurosurgeon to give a different perspective of microscope from a neurosurgical point of view. So myself, Dr. Neeraj Vasavada, I am from Ahmedabad, Shalby Hospitals. Then we have Dr. Ranjith Unnikrishnan, who is from KIMS Hospital, Kerala. Dr. G. Balamurali, who is a neurosurgeon, head of department in spine surgery at Kaveri Hospital, Chennai. We have our all-time favorite, Dr. Vishal Kundnani, from Mumbai, multiple hospitals. And we have another star, Dr. Satyen Mehta from Mumbai, very expert in minimal invasive and microscopic spine surgeries. So today's topic, we are not going to discuss much on theory. We are not going to present long presentations. This is just a discussion and, our experience with migrating from hardcore orthopedic open-eye surgeries to using microscope and getting addicted to microscope, and what struggle we faced, how we overcome, and why we feel that it is something which is unavoidable to imbibe and to adapt to microscope. So just without much ado, we'll just quickly take few slides at how and why microscope helps. So physics says that without any magnification, the human eye has the ability to distinguish between 2 discrete lines separated by space of 0.2 millimeter. That means your 2 points should be at least separated by 0.2 millimeter for an eye to differentiate it. If it lines becomes closer than that, the eye will see them as a single line. So I will not be able to differentiate between 2 points. So microscope, by virtue of magnification along with illumination, can probably widen this gap even when the actual gap is quite tiny, and we can study the details of microanatomy. The Carl Nielen, he was a Swedish otolaryngologist, and he first introduced the microscope into the operating room for the treatment of patients with chronic otitis media. And it was Dr. Yazergil, a neurosurgeon, in 1977, modified the traditional discectomy to microsurgical discectomy using a surgical microscope. Despite the apparent benefit, there was a survey conducted by Japanese surgeons in 2004. They studied around 14,917 spinal surgeries, and they concluded that only 1,651, that is 11.1% of total spine procedures during 1 year period, where microscopes were used. And if you further differentiate it into, it was used in 91% of them. Out of 11%, 91% of them were for intramedullary tumors, while only 15.70 for disc herniation and other pathologies. So despite it was first used in spine surgery in 1977, that is roughly, we can say that is around 50 years back, still it is not widely accepted among orthopedic spinal communities. Possible reason could be lack of exposure during training, low rates of utilization in general orthopedic procedures, a less emphasis on microsurgical techniques. So do you think magnification is important? Let me bring in straight away our neurosurgeon, Dr. Bala. Bala, how do you see that? Your residency, you went from a general surgeon to your specialized MCH in neurosurgery. Why magnification was important? Purely spine point of view, not the cranial or a tumor point of view.
Yes, hi Neeraj, thank you so much. Let me first explain to you about the importance of why you're actually emphasizing on microscope today. Is the very fact that people feel that magnification is whether it's only magnification or whether it is the illumination. First, I would say is that illumination gives you a broader vision, lighting to see the pathology. But illumination alone, initially, before Yazakil came, we had a lot of illumination technology that came with high, lights and other things. And we have headlights. Then we had the evolution of lenses, wearable lenses, and then came microscope. So the microscope can be magnified 2 times, 4 times, and much more now. So I would say I do not have the experience at all of having operated anything without a microscope. So I really cannot say that how I shifted from that. But as you said, as a general surgeon, as an orthopedic surgeon, I have trained and come that way into neurosurgery and spine surgery. Now, I would say for the trainees who come, for people who come, people think that this is something very difficult to adopt. People think that hand-eye coordination is something that is difficult. For any surgeon, research says that hand-eye coordination is the key. And when you come with a microscope, it is about hand-eye coordination and distance. So it is all about the working distance that you are. Whereas for an cranial case, your distance would be deeper inside. For an obese patient, the distance is different. Whereas for a spine patient, it's different. For a pediatric patient, it's different. So it is hand-eye coordination along with another axis, which is the X, Y, and Z axis, is your distance. So when you're able to work in that distance, everything becomes easy. So I would say that there is a mind block for a lot of people that, a microscope is difficult. There's a long learning curve, that it is, you would have all noticed that when you have a microscope and you have your assistant nurse or a technician using with you, in about 5 to 10 cases, he becomes extremely good. So my conclusion really is that, yes, there is a hesitancy for many people to shift from, open eye surgery or loops to going to microscope. But I would say it is very easy, and all you need is a 5 to 10 case of exposure and a little bit of practice, more of the depth perception. Because illumination and your light is magnification is fine, but the depth perception is important. And I think nowadays, this discussion is slowly becoming irrelevant. Maybe in the urban areas, but still in the rural areas, yes. But I would say that, definitely there's a small learning curve, but it is not as steep as other procedures.
So as Bala pointed out that, adopting a microscope, it is all about just, having a hand-eye coordination and will to use it. Vishal, if we remember, our days when we just, came out of orthopedics and went to spine surgery, I'm sure, our Bombay, Chennai, our top guys, they were more into using loops and headlights, right? And probably we went abroad for our fellowship. So first I'll take to Vishal, then Ranjith. We suddenly show a different paradigm that, the surgeons abroad, they were using microscope. So what change do you notice, from going from a headlight loop to a microscope during your training in spine surgery? And do you feel that, I guess this could have been imbibed in our training quite earlier during our orthopedic residency?
Very interesting, Neeraj. I think this question has always been lurking in mind. And frankly telling you, when I started my fellowship abroad, where microscope was the only way to do neural decompressions and minimal invasive spine surgery, the first question was resistance. The first emotion, the first feeling was, why are they using this? I mean, I have been doing open surgeries for all this while. What is the need of a microscope? Why are they using it? And that resistance was the first block that not only increased the time I mastered microscope, but also it was the major impediment to the world of microscopic magnification and illumination, which obviously has very, very obvious advantages. Now, what are the advantages of microscope? Are very obvious. We all know that magnification, illumination, better visualization, angulation that you can achieve with microscope are just not possible with the naked eye. But in practical sense, I think 2 things that microscope has added to my practices. Number 1, I have become far more confident. So my applicability now to take up a complex case, I don't worry, because I know I have an armamentarium of microscopes to me, and I can actually visualize any neural structure, any vascular structure far better than what my eyes can do. Number 2, my USP has gone better. So in practical application, what a young surgeon, why should he instill his confidence into microscope? I think the first and foremost is that you will be able to do surgeries which otherwise an open surgeon or a guy who's not using microscope will not be able to do even by using loops. Second is, I think vascular, the bleeding part. There is no comparison of blood loss when you do a microscopic surgery versus a open eye, naked or a loop surgery. With microscope, you can visualize vascular structures well. Your bipolar cauterization is better any day. And also the safety of surgery, because you are able to see neural structures better. The handling is far less. The chances of you landing into neural injury and even paresthesia, post-operative paresthesias have gone down by the use of microscope. And I would strongly recommend, please, if you have not done till today, start using microscope, because it definitely does has a learning curve. But the first step towards getting into the learning curve is, please wipe off your slate that microscope is not useful. Unless you get a clean slate, your learning will be not only slow, but the learning curve will seemingly be a steep one, which otherwise it is not. And the moment you get a clean slate and you start having a conviction that microscope is advantageous, it is beneficial, the moment you develop this conviction, believe me, the learning curve is the smallest part of the benefits of microscopic world.
Right, Vishal. So Ranjit, I mean, we both probably trained from the same center, and like me, you probably was also with hardcore orthopedic spine guys, and suddenly you went to an institute which don't operate anything without microscope. So was it an eye opener for me? One, I remember that, I mean, I never saw the anatomical details, which actually was probably observing, being an assistant from the senior surgeon who was using loop. And suddenly I'm seeing everything with multifold of magnification and clear lightning. So it was like a flash of light, passing through my mind, and sudden realization that what I was missing. What was your experience?
Thank you, Neeraj. Glad to be in this elite company. And Neeraj, like what the previous Dr. Neeraj, like Dr. Vishal and Dr. Bala mentioned, it is actually a paradigm shift for me. I'm sure it's a paradigm shift for anybody who gets exposed to it, especially when you're coming from an orthopedic background, because magnification and illumination has added a long way towards the safety in spine surgery. It's safety. It's not about convenience. It's safety. The way you handle the neural tissues. Your fine movements become more precise, because the usual jerky movements become more amplified under the microscope. So you tend to be very, very careful. You really kind of synchronize yourself, and to add to the points which Dr. Bala and Dr. Vishal mentioned, I think it is no more a luxury. It is a necessity. If you're doing spine surgery, microsurgery, a microscope is not something like a navigation, which probably you can kept in as option, but this is kind of essential for patient safety and improving outcomes. Regarding that hesitation part, I'd like to share a snippet. When I was a resident, I had a particular surgery in which there was a complication. So it was doctor's relative. So the doctor asked the then chief that, did you use a microscope for surgery? So his answer was, what do you think? The microscope will do the surgery? So I thought that microscope is, kind of a gadget which is kind of flamboyant, nothing necessary. But today it is a 360-degree turn for me. I cannot think of any surgery where I'm handling the nerves, especially in a microsurgery, without using a microscope. It's an essential tool for me, Neeraj.
Right. So it's all about, probably getting adapted to the new technology. Satyen, for you, you probably got trained into MIS surgeries. Again, how important this magnification and illumination is all the more important while doing an MIS surgery. What is your experience with that?
Yeah, thanks, Neeraj. As discussed with by all the other faculty, you cannot basically perform any MIS procedure without using a microscope. It is all the more important in cervical spine surgeries, especially if you are doing an anterior surgery.
Training in the hospital. Now, this actually did not happen.
Yeah. Can we mute
only
Vishal?
By the large quantity of clinical work. People come because they
have to mute Vishal.
Papers. They know that there is a good research, there is a questioning mind, and there is a group of people who are finding solutions. And
Vishal,
that makes you respectable.
Vishal, you got to mute.
Population. So I would really wish
So
all of you very well that you should not only be successful.
if you are the
Can you call
moderator,
Vishal
then
and
you
ask
can
him
do
sooner
to
you
mute,
become
please?
a clinical scientist, that will help you to reach rich dividends in your profession. So wish you all the best. I should congratulate
Karthik, can you call
the
Vishal?
BOS and the OrthoTV for starting a.
Sure, sir. Let me call him.
Yeah, can you can mute him if you are the host.
Yeah, the host is Neeraj, actually, Neeraj Bijlani, so he will have to probably mute him.
Thank you very much, Rajikran sir. And next, I'll share the video received from.
I think his BOS is also going on simultaneously.
Going on. Yeah.
Yeah.
So, anyways, coming back to our discussion, for MI surgeries, we definitely need to use microscope in everything. It's very difficult to do it without that, and especially in anterior cervical surgeries, it's almost a must to do with a microscope. Now, one point which we haven't talked about is what I wanted to tell you is, it's a very important training tool as well. When you're doing these surgeries, your assistant is not able to see into the depth. He's not able to get his illumination. He's not able to do a proper color differentiation with your normal loops and headlights and all. So for him or her to be able to see it and to appreciate what is actually going on, this is a very useful training tool. And not just for them, also for the entire OT staff. The nursing staff is also able to see what is going on the screen. The anesthetist is able to see, and it kind of helps to bring all the team together. They feel like they are part of the team, not just they're just standing and having equipment if they call. So that way, it's a very useful tool if you're using that.
So just to show that, what people has been talking about, if you see this video, how magnification can really works wonders. The initial images, this are of naked eye. And when you start using microscope and actually, start magnifying, you can see that how beautiful it magnifies along with a beautiful illumination. To see actually individual muscle fibers, you can very easily be able to differentiate the facet capsule color from, this is the facet capsule whitish color along with the muscle fibers. And if you see while operating, you can see the nerve root structures, epidural space, small bony remnant, bony fragment, and this actually improves the surgical safety for the patient. Then comes the ergonomics of spine surgery. Spine surgery per se has been a long surgeries which requires longer focus, mostly with bent neck with varying focal lengths during surgery. So microscope does help us, safeguarding our neck and other structures. Ranjith, your take on this, how, because I remember when we do scoliosis, where we don't use microscope, at the end of the day, we do get tired. So if we do a deformity surgeries, MIS using microscope, how does it help in this, in your day-to-day practice?
Yeah, Vishal, Neeraj, I have never done a scoliosis with a microscope.
Of course not. Yes. So I'm just asking you to compare between a scoli and a microscopic surgery.
Yeah. So given a choice, I'm very happy when I have a microsurgery because I know I can look straight. Whereas when I have a deformity surgery or something, I have to look down. I know I will end up with a painful neck that night. So I really look forward when I have a surgery with a cervical disc or a lumbar disc or an MIS, etc., or an endoscopy where I have to look straight and do the surgery. But I know when it is open, thankfully, I don't have so many long opens back to back, but we have those microsurgeries back to back. So really, it's a great boon if I can use a microscope because it's really kind on my neck. And I believe there's also a publication from Bombay by Dr. Abhay and his team, which looked at the surgeon's neck pain, comparing loop versus open versus microscope. I believe they came to the conclusion that there is significant less neck pain when the surgeon uses microscope for all his surgeries.
Right. So Vishal, are you there or you are busy with other webinars?
No, I'm here, very much here.
So he's okay. So Ranjith said that Abhay Nene's group has come up with so let's go to Bombay guys. Loop and microscope. What difference you find?
Major difference. I think most of them
ergonomics, ergonomically, surgeons fatigue, all those stuff.
Oh no. That is all that is very subjective. We have had surgeons who have had problems with loop in terms of neck pain and back pain and headache. And then we have a group of surgeons who have had microscope related neck positioning or back. Because microscope on one hand results you in keeping your neck straight, but your back surely goes into hyperextension. On the other hand, the neck is flexed and fixed to one position when you're using a loop. So all those are very subjective, and to this I would say a fit surgeon is a fit surgeon, and he will never have problems either with loop or a microscope. And all the problems that are associated with neck pain or back pain associated with magnification are only very, very subjective. I have been using magnification with microscope for almost more than a decade, and touch wood, at least till day, I don't have any problems in terms of back or neck pain related to microscope. Whereas I do feel that by using a loop, I generally tend to get headaches because of keeping my neck in a fixed position, and because the focal length varies the moment I change my head position. So for a tall surgeon like me, I think having a fixed focal length using a loop is a major problem. The other problem that I face with loops is because of fixed focal length, the position of the table in relation to the head gets fixed. So if your head is here, it will remain here. You have to keep it here. If you move even by few millimeters above, then the problem is that the focal length will change and you will have a sudden change in your vision, and you may start developing headache. And the other thing is, in certain times when you want to keep your neck or head in a more ergonomically favorable position, the table has to be brought upward, where your hand ergonomics of using forward carries and punches may not be conducive for doing that particular decompression or fixation procedure. And that is why these few things which microscope will give you, not only manual but also nowadays digital autofocus mechanism that are available with modern microscopes, I think microscope definitely gives you an advantage of keeping the table at a more ergonomically conducive hand placement. The height of the table doesn't need to come up, and the height of the table primarily can be fixed as per the surgeon's hand ergonomics rather than head ergonomics. So the most favorable thing for patient is to have surgeons hand ergonomics in favorable position, and surgeons head ergonomics can be then managed by using the focal length variable around the microscope, which is not possible in a loop.
Right. So Vishal pointed out that, even surgeon using microscope with long surgeries, especially when we are doing L5, S1, we tend to, twist our backs to align ourselves, rather than twisting the eyepiece. So we'll go to Bala. Bala, neurosurgeons operate, also equally long surgeries. What about surgeon fatigue, using microscope? What is your experience with that?
Yeah. So I think I just want to stress a few points in terms of surgeon fatigue. Number one is we need to know about how to utilize and use the microscope. So I think our conversation today from this point onward should be focusing about how to use the do's and don'ts of microscope. So the do's and don'ts are so important because when you're doing a 10-hour, 12-hour surgery, you will be standing in a static position, but you will have to move your microscope like you would move your head. Remember that the modern microscopes have a 360-degree turn in which you can do it. So you can not only tilt the table and adjust the height of the table, but the microscope can move in so many directions. So you need to know your microscope very well. So that would reduce your fatigue. Second thing, I know we discussed about the head position and whether it will hurt your neck or not. And that is because when you're sometimes engrossed into your surgery, and when you move your microscope slightly, you tend to either extend or you tilt your head to one side or to flex too much. So this has to be constantly noted when you're doing a long procedure. Second thing is, when you are doing procedures especially at different heights, so you're managing with the dura and you're in high magnification and you want to go a little bit into the nerve roots when you're doing intradural, intramedullary procedure. Again, there you tend to adjust your magnification, and that would alter things, and you again tend to change. So the position in which you stand, the way you adjust your head, and if you want to see, say, somewhere deep inside to one left side or right side or over the top or on your same side, so you need to change the microscope and not just only move the table. The microscope can be turned in so many directions. So that you need to know. The second thing is, you have to know how to adjust the table height when you want the table to go up, down, where you keep. So positioning is so important. Using the microscope is so important. Not all microscopes are very high tech, can do this 360-degree kind of a turn. Some have very fixed motion. So you need to understand that. And I think these are the simple steps that you can do. Certain procedures in the cranial, we do tend to sitting down because your hand also gets very tired. It's not just your neck, because you're in a very static position. And if you don't have the right equipments, and you're not using, for minimal invasive through a tube, you're not using bayoneted instruments, your hand is hanging in the air and your hands get fatigued as well. And at the same time, your leg. So your leg position, again, you need to have a step sometimes when you're doing long procedures. So all these little things, because once you're in deep inside on the spinal cord or repairing a dura, your focus and everything is there that you forget about your physical posture. And all you do is at the end of your surgery, if you're doing 10 hours, the night and the next day morning is usually bad. And it's not that time when you're operating. So I think these are things that only comes with practice.
Correct. Satyen, to you, there has been few concerns with those who are not using microscope or little afraid about microscope has lot many portals and parts to take care of. And there has been some apprehensions about that loops are safer because it shades bacteria lesser. And if you are doing multiple surgeries, one and after another, microscope may lead to infection. There is a notion prevailing. What's your take on that?
So I think that if you are not used to handling the microscope, there is a chance that there is a tendency that you may be touching more here and there, and there is a chance that the infection rate would be higher. You need to be sure about what you're doing. You have to bring it in at the right time, and you don't have to straight away jump on the microscope for complex surgeries. For people who are beginners, if you need to start with the right thing, use the microscope around without a patient, maybe try to peel an orange under it, get a proper depth perception, play around with it. Maybe when you're doing your open surgery, then bring the microscope in and see how you would do it, or see the nerve roots under open surgery with the microscope, and then graduate onto the actual microlumbar discectomy and then further ahead. So if you follow those steps, then you should be all right. Otherwise, it's actually very easy to use the microscope. There are only two buttons which you need to basically be aware of. You need to know your focal length. You need to be able to adjust, and then you've got your remote to change your position with the height up and down. And if you take care of that, then you're all right. Now, one point which Vishal had made earlier is about the fixed focal length microscopes, the ones which have got fixed magnification powers. Those are the older ones, the cheaper ones, and the ones which are usually available on rental basis also. They don't really give you too much of magnification. They don't give you as good of illumination either. And he talked about that you need to go closer down, you need to bend down maybe, and the working length between your table or your patient and your microscope is very limited. And if that working length is less, then you may end up touching the microscope while you're operating, and that is always a problem. So if you have a better microscope, like the ones who have sponsored our program, the working length increases. These have got a stronger lens, and hence your focal length is more. And so you may have a much more working length, and so the chances of touching is lesser. And also, once you got to be able to bring your microscope in properly. You don't need to keep touching your eyepieces again and again. Avoid that. Again, that would be easier if your microscope is a good strong one, and you don't need to keep adjusting it. The light and all is perfect. So it just comes in one position, have a good focal length, and then you are good to go. The chances of infection become much lesser.
Right. So if we look into the literature by head-on-head comparison between magnifying loops and a microscope and micro decompression surgeries. So the data suggests that leg pain, back pain, or a patient-reported outcome satisfaction rate has been more or less statistically significant. But if we look at the other data in the same paper, they reported early return to work to functional status while microscope was used, and modified McNabb criteria was much better with statistically significant p-value in patients where microscope has been used. So maybe it goes with the precision of the surgery. Illumination we already talked about. It gives us illumination at a very in-depth portion So illumination also helps along with magnification. Majority of the time, loop does give us the magnification, but headlight along with it may not be able to give you equal amount of magnification. I'll come to Bala. While using illumination, they say that microscope direct light on this delicate neural structures. If you keep it on for a long time, high intensity light, it may lead to burns. What is your take on that?
No, I haven't come across any specific literature on this, and sometimes I've operated on patients for many hours, and I don't think that is the case. If I'm wrong, please do correct me. But what I feel is sometimes we never operate 10 or 12 hours in a stretch. You normally take breaks for 10 minutes, 15 minutes, 20 minutes, and in those times we have to make sure that we switch off the microscope. So maybe at the end I'll give you a few more tips which I could say about what you should not do, but that is one thing that we have to do, but I'm not aware of any literature on that.
Okay, Vishal, your take on that, the heated light, which goes inside, does it damages the tissue? What do you think? Have you ever experienced that tissue burns? Vishal, you there? Okay, Ranjith, your experience.
Yes, in this concern, I've had concern because if you do today's, apart from what Satyen mentioned, today's microscope, all of them have got magnetic locks, all have got variable focal length, all of them have got variable magnification, all of them have got variable IPD distance adjustable option. And the light source today, we have two of them, right? Most of us have gone off from the xenon source, from the argon to the xenon source. Now with the xenon source, I have noticed especially on the dura, this is more so not for microscope. I don't do any open spine surgery also without a headlamp on, because the small incision focused lamp. With the headlamp on, I've noticed dura drying up. I can see dura drying up when I use the headlamp on. I'm not had it with microscope because there is constant irrigation. Typically, when I do a VCR kind of surgery, wherein the dura is exposed, the roots are exposed, I have noticed that when I have the headlamp on, the dura dries up. So it's a practice for me to frequently, irrigate the wound, and I can see classically that the dura becomes very transparent when it is heated at a focal spot for a long time. So I do concern that there is a concern about heat, not with microscope generally, but heat on the dura. With the microscope generally, we tend to irrigate, so that doesn't happen. And Neeraj, apart from this concern which you mentioned, and I believe Vishal was telling about using loops causing fixed focal length. Satyen, it was not about microscope, I guess. He was using about loops causing neck pain. So I hardly have used loops, even though there are advantages of loops when you're a traveling surgeon, you go to many places, you cannot carry your microscope with you. So then the price you pay is neck pain, so illumination in every cases, magnification whenever possible, and whenever possible, illumination and magnification with a microscope, which saves your neck. Right. Now, have you had concern about sterility when you use a microscope?
Sorry, come again.
Have you had concerns about microscope?
Well, yes, I've heard few people, talking that if you don't handle microscope significant properly, it may lead to, well, there are some literatures. I think I might have included that thing into the talk. So I think we'll go to that later. So what we were talking about, especially is more important. The microscope gives you a varying degree of magnification. That is one very important point. If you don't want a higher magnification, you can probably operate at a lower magnification, and you can magnify it as and when required. So that part is not there in the loop or naked eye. We have a fixed magnification when we are using loop and naked eye. While in microscope, according to the structure, say for example, this video, you can say this is the cervical ACDF which I'm being performed, and this is the PLL which is being cut. You look at the kind of magnification we are getting to put the knife directly anterior to the dura. Now, it is not impossible to operate under with loop or a naked eye with experienced surgeon, but this kind of a safety and clarity which is visible in microscope is seldom to be found in other modalities of the thing. Learning curve, I think we already have spoken about. Vishal has spoken about, Satyen spoken about, and so you and your assistants, maybe 8 to 10 cases if you operate under microscope. you get proficient enough. The only challenge, when I was adopting to microscope maybe 15, 20, 17 years back, was using a high-speed drill. Satyen, your take on that? Vishal, you are there?
Yes, very much here.
So
Very
I think,
much.
your adopt. See, one thing which I was always afraid was when I started using microscope in my earlier days was to use a high-speed burr at 75,000 RPM right anterior to the cervical spine PLL or a OPLL. How did you, get over that fear initially? What was your training?
So yes, it's true that learning curve of microscope does exist, and in initial days it is fearful, but it is not about the visualization of structures. It is primarily about handling the instrument per se. If you have learned how to handle the instrument, if you have learned how to focus on a particular subject, how you can manage the focal length, if you can learn the depth, and we are all trained to see at the structure and operate. So our hand-eye coordination works in that way. However, gradually we have to see that we are looking away from the structure and still our hands are working there. So this may take some time, but I think the fear is more assumptive rather than for real, because even in initial days, I don't see a reason that you should be afraid of using a microscope, because just because I had early 20 cases versus last 20 case analysis, the complication rates or problems never increased or was not different in the first 25 to the last 25 cases. Yes,
okay.
My surgical timing was a little higher in the early cases, and it is purely because of the assumptive fear that I'm doing in a different manner the same surgery for same outcome. But gradually, as you see, not only your surgical time gets better and better, your complication rates get better and better, your blood loss keeps coming down and down. And as you tame the machine of microscope, you will actually start enjoying it more and more. So it's like an automatic car versus a manual car, where in initial days, the automatic car seems to be a little more finer adjustment which is required. But once you start enjoying it, it is a seamless process, Yeah.
Right. So Ranjith, if you remember when we were being trained at abroad, I think we were not allowed to use drill till the time, we were put into practice lab, we were given an eggshell to drill. So maybe, you can narrate that incident,
Yeah.
So how did you got used to using drill, how many eggs we punctured while you doing all those things?
Yeah. So it's like, what Dr. Bala mentioned, he cannot do any surgery without a microscope, because I think that has to start at the beginning of our training. We should not be taught that microscope is something which you have to learn extra to, you are not trained separately how to use a power drill as an orthopedic surgeon, right? It's part of your armamentarium. Same way is a microscope for a spine surgeon, right? You should know it's part of your tool. Now we all were open trained orthopedic spine surgeons. So when we were put to this center abroad, when we all trained, so we were actually given eggs. So it was one of the best part of my life, which I really enjoyed. So we used to see how the spine surgeons to really beautifully, we were trained classically to do all OPLs anteriorly. We had to go anteriorly, peel off, drill out the entire OPL, float them, etc. So it was really a treat to see them drill on the OPL with the dura. So we were like, I asked the boss, can I do it? He told, yes, fine, you can do it, train yourself. So we were given an egg, and every Sunday we had to shell off half of the egg without breaking the membrane, and then we would, then I thought that the nurse would give us 2 eggs. So the 2 eggs would take a minute to break for us, So we used to go to the supermarket, buy a rack of egg, and start drilling it. And I remember nearly after around 15 to 20 eggs, kind of could get it a quarter way up. And one fine day, the boss told me, come on, start drilling the OPL in the case. I was like taken aback. How did he know that I will do it? So the case went over. In the evening, I asked him, boss, why did you give me to drill? So he had a smile, and I didn't understand. So later I still asked him, please tell me, why did you trust me and why did you give to me? So I did not know that every Sunday when I was breaking the eggs, it was being recorded in the camera. So the boss would, the next day morning, the boss would check how many eggs I broke or I blasted drilling it. And then when he saw that consistently on 2 Sundays, I could make out nearly 3/4 of the egg without breaking the membrane,
that is when he gave me to know to drill the dura. So that is very interesting. We all should go through it whenever possible. Spend time and get that skill. It really helps a lot.
Correct. I remember my score was 18 eggs. After 18 eggs, I actually burst open. Then I think the 19th egg, I was able to do good drilling on the egg. Bala, your experience, I'm sure you will have some good incident to put into the perspective, because you probably started using microscope from very early days. How you all got adapted to this microscope?
Yeah, I think it's true that I should accept that I was lucky enough because I did all my training abroad, and from day one I used microscope. But again, one thing that we were always taught by my boss, we had, like, for example, we had 5 or 6 operation theaters for neurosurgery, and there were only 2 microscopes. So you would always have a little bit of a tough for microscope, and suddenly you'll have an burst aneurysm where they need a microscope urgently next door. They have to rush in an emergency, so you're left with no microscope. So though you all have learned to use a microscope, you have to learn to use either loops or you have to learn how to convert an microscopic surgery into an open surgery. This is something that everybody has to use, because even in the most expensive hospital, you can only have 2 microscopes, and sometimes microscopes are shared now between ENT, ophthalmology, neurosurgery, spine, and your bulb can go bust and your microscope can stop working. So I think I've also gone through that phase. So I have used loops from time to time. So it is good to have a practice with loops and be able to operate without a microscope. But having said that, now, if I have at such a situation, and if I'm doing a really complex case, I probably would even close up the wound and come out if I don't have a microscope, because I feel it's unsafe. I don't think I can do an operation without a microscope, especially if I'm doing something very, tedious and intradural and stuff like that. Whereas a discectomy, I probably could manage if I find loops with headlights. So we have to learn both of that. And I think, we have to be prepared for that. No matter how big a surgeon you are, you could be caught up in a situation where you may not have a microscope.
Right. Satyen, being an ortho surgeon, challenges you faced while adopting yourself to the microscope, the technology which, if not rightly used, may lead to more problems. So what challenges you faced? What you can remember your challenges?
Yeah, as I told you earlier, you need to go step by step in when you're using the microscope. So you have to start with just inanimate objects when you're doing that. As you said, the egg shelling is a very good procedure where you get a very good depth perception, and you're able to, get an idea about how much to push, etc. So that's a very good one. So you got to try to do more of these before you start off with your actual procedure. And when you actually start off with your, surgeries also, you shouldn't be afraid to convert it into an open procedure. So in the initial days, there have been instances where it's been very difficult to actually identify, although, the microscope is very useful in color differentiation. So if you see your dura, your ligamentum flavum, and your disc, they are all actually white. They're just different shades of white. So your ligamentum flavum is a yellowish white color. Your dura is a little bluish white color, and your disc is a little bit more of a pearly white or a little pale white color. So if you use a normal light or if you use a yellow light, it will sometimes become very difficult to differentiate between these 3 structures, and it may look like the same.
But challenges what you faced, while what difficulties you find while adopting to all these things.
So when you start off, there will sometimes be difficulties where you may not be able to identify the structures very well, even with your microscope. If you're not used to it, you may not get a very good depth perception. Even when you're doing MIS, sometimes, in the initial stages, instead of going onto the facet, we've gone onto the spinous process also, and thought, okay, maybe, and thought, okay, oh my God, something is wrong here. So you shouldn't be, worried too much about changing it into an open procedure if you have a problem. So that is what I'm trying to say. If there is any problem while using your microscope, it could be challenging in the beginning. You shouldn't be worried about just leaving it and opening it into a normal open procedure and doing the procedure more safely, making a slightly more bigger incision or having a slightly more invasive approach should, is always acceptable, but a complication is not acceptable. So you've got to be okay to convert that. So these are all the steps which you go through in initial stages when you're using your microscope. Even when you are trying to do, supposing an over-the-top decompression onto the opposite side, if you're doing a right side decompression and you've done from the left side, it may sometimes be challenging to actually get to the right depth perception. You may end up removing too much of the bone on the opposite side using the upward Kerrison punch. So these problems can definitely happen, and with experience, you get better and better with it. And if you have any doubt, better open it up and see it and do it properly.
Right. So far, three major challenges came into foray. One is, as Vishal initially said, hand-eye coordination. Second is depth perception, color perception. And maybe, initially getting adjusted to your microscope per se entire. Vishal, these days now, the endoscope has also come in a big way in spine surgery. How do you see, microscope, endoscope, your perspective in both the things? Both are, basically optically magnifying equipments, both more or less uses magnification, illumination also. So how do you, not technology wise, not indication wise, microscope and endoscope, basic things, what you see when you are using these two things in spine surgery?
Again, like loop versus microscope has its own differences and advantages versus disadvantages. So has endoscope. The major advantage of endoscope is that the size of incision and morbidity surely goes down. But it comes with its own set of disadvantages, that the indications for the amount of effort, learning curve, and resources put in are very limited. So cost-benefit analysis, effort-benefit analysis, to me is not in favor of endoscopic spine surgery. However, I think people who do endoscopic surgeries will vouch that they can deal with most pathologies, if not all. I still feel that there is a completely different world of microscopic surgery, and we really cannot compare apples to oranges. And I think microscopic spine surgery not only gives me a wider applicability, gives me a better application in the thoracic spine, cervical spine, lumbar spine, but also has its own advantages, like we all discussed here right now.
Right. So I think, it's a very pertinent point that endoscopes are not actually extensions of microscope. These two are different paradigms, different ball games altogether. Microscope per se is more versatile than the endoscope. I think, we are more or less coming to an end. But before we go, I would want to bring in Bala. Bala, these 3D microscopes, how does it change your practice? Because in spine and neuro, 3D microscopes.
Yeah, so I was just going to say one of the important things is the microscopes now can do a lot more than just, visualization and your illumination. So 3D is one of these new features which has actually brought in, and we do have a 3D microscope. We have ZEISS microscope, and I would say it's fantastic. But the 3D microscope really, unless you have combined it with an exoscope, which we don't have, it actually only has a huge benefit to the person who's viewing it. So it is a good learning tool. It's a good tool with which you can record it. You can use various things, like you can use fluorescent dyes, you can see blood vessels, you can navigate through things for tumors. You can it kind of synchronizes with many navigation. So I personally feel that the 3D microscope is more of a learning, and it is more for the person who is visualizing it with your 3D glasses. Not so much so, I would feel, for the operator. This is my own feeling. But technology is still getting better. And I think the depth perception, I think for a standard spine surgery, disc surgery, T-lift, none of these things, I think a 3D microscope has any value. I think where it has value is in tumor surgery. It has a value, probably anterior cervical surgery, probably skull base and craniocervical junction surgery. These are places where I feel there is a lot more, and for intradural work definitely, but for standard spine surgery, I don't think 3D, in my opinion, has a major benefit.
Right. So I'm told that we only have now 5 minutes left in this symposia. So we'll start closing comments from all the speakers. We'll start with Vishal. And finally, Bala, we will request you to give some tips and tricks on spine surgery to budding surgeons. Vishal, your closing remarks for younger surgeons who are trying to adopt to microsurgery. Vishal, then we'll go to Ranjith, Satyen, and finally we'll close with Bala. Vishal? Okay, Ranjith, you can take over till the time Vishal comes online.
Yeah, so for surgeons who are trained in open surgeries, the way to convert is that when you're operating, try to close under the microscope first. Try to suture under the microscope first. That's how you get your hand-eye coordination first in your open surgeries. Then later on, as you learn closure, then try to do your open surgeries under the microscope, and then start using the drill. But make sure that you develop that skill. It's not difficult. We have learned all these things to use drill and all those things. So we can very well do it. It's not a big issue. So plus, don't look it as a gadget, which is an option. It is a necessity. Once you know it's a necessity, you will learn it.
Right. Satyen, your closing remarks.
Yeah. So I think it's quite easy actually to use this. It's not as difficult as people make it out to be. You just need to start doing it, get over that mental block that it's a problem. You just start doing it, and gradually, as you've got to upscale yourself, and you will be able to do more and more procedures, on your own without any difficulty. So it's not really a problem, and you got to try to use it in more and more cases. The more you use it, the better it will be, the faster it will be.
Right. Vishal, you are there? Okay, so for me, microscope is apart from all other speakers said, one of the most important tool when I'm doing a revision spine surgery or operating at a craniocervical junctions. Sometimes anatomical details are so messy that you really find it difficult to identify structures and things on your naked. So for cervical, it is absolutely necessary. Whether you are doing open surgery, MIS surgery, I guess that saves your patient to a multiple. One thing which I have noticed so many times that sometimes when you are operating under magnification, slightest movement is exaggerated under microscope. So you tend to actually safeguard, because you suddenly feel that okay, you are trying to do an extra movement which may endanger spine, but at a naked eye, those movements are even not happened. So microscope exaggerate your wrong movements, and you can by that also safeguard your patient. So microscope for me is absolutely mandatory for all MIS surgeries, majority of my revision surgeries, every cervical spine surgery, and selected classical open surgeries. Vishal, you there?
So Niraj,
Neeraj, I was just
how do you sterilize your microscope, Dr. Neeraj? And
sorry, for us, we always use a sterile cover after every surgery. I actually skipped the slide, but since you have brought this here, more or less, this the worry why I was saying that the of infection comes into place after surgery. The frequent areas which we actually keep on touching is like eyepieces, your hand pieces, where your forehead touches. All those areas have a multiple bacterial contaminations which has been proven in surgery. So after every surgery, you have to clean your microscope thoroughly with bacilloid solutions and your sterile solution, whatever you are using in your OT. And I tend to use surgical drapes, fresh drapes for every my cases, so that the contamination or a cross contamination doesn't happen in our microscope. What do you do, Ranjit?
So for me, it's almost same. The overnight it is kept in formaldehyde case, and I use drapes. I use actually gloves. I use gloves because to save the cost. I don't drape the entire microscope, only drape the hand pieces wherever I touch, and I don't touch. Once I set my eyepiece, etc., I remove the gloves. I put one glove on the hand piece, and that is it. I don't touch anything else. So that is it. And even we don't clean the microscope as such after each. After each surgery, it's cleaned with bacillocid, but not any sterilization as such, but keep on changing the hand covers. That is it.
Right.
And I've not had actually a very interesting point.
Any infections because of microscope.
Acha. Yeah, we were actually, one of our centers was doing that. We were putting formaldehyde, just those tablets, and draping it around overnight and just cleaning it with bacilloid between cases. But I was always worried about the infection rate, but it's a good point that you brought up, that it doesn't cause any problems.
No, I have
one point which I was
data of nearly
there has been. Yeah, same here. I think initial cases, we were also using same thing, formaldehyde cover and the microscope. We used to keep it for 7-8 hours, and then we were using gloves. But maybe now with our hospital policy, we have made it mandatory that we have to use sterile wrap for every
And
patient and clean between surgeries. So Vishal, if you are not there, we'll go to Bala.
Yes, I think, that's a very important point. I was just going to ask, but you brought it up. Sterility. We use the same thing, formaldehyde, but we drape every microscope. I think also the newer microscopes, they are very cleverly designed that you have to have a drape.
Yeah, and
without a drape, you cannot use the microscope. Yeah, so I think in a way it's good. It probably adds, a few thousands more, but in the overall picture, your surgeon, you're happy, everybody's happy, and we really don't know what's right and wrong. But if you touch the eyepiece, if you touch anything, you have to make sure that you change your gloves. And usually during any long surgeries, I change gloves every 4 hours. The second thing is, I think there's a very important learning point for juniors. I think the microscope has changed the way that we learn microsurgery, because you have somebody who can view the microscope along with you, whereas when you're with an headlights, you're always butting against your assistant. He doesn't see clearly. And also important to some people, I've seen they operate just the surgeon and assistant have the microscope, but they don't connect the monitor, because your nurse also needs to see. And, she also has to have a monitor. It's very important. You should make sure that you buy a small television and, any microscope gets connected to a screen. Some other few tips is rotating the microscope. I've seen sometimes juniors, they just keep it in a fixed position, a little bit of tilt, but really you can, like how you would move your neck around and see in all directions, you should move your microscope. Sterility is important, and always have a backup. Make sure that you have a bulb. Make sure that the number of hours your bulb has been used is seen by your biomedical department. And if suddenly your bulb goes off, you have a spare bulb in your hospital. So these are things that you have to check with your company and your hospital and make sure it's worth it. I think we have to go away from thinking it's a big investment, that whether it's cost effective in smaller hospitals, whatever hospital you can, whatever affordable, I think a microscope is a necessity. And the modern microscopes can do a lot more than just visualization. There are so many features that they have come up with, and which is very beneficial, and try to understand that. So buying a ZEISS microscope, because it's a ZEISS program, I'm saying, it's like buying an iPhone and just only using WhatsApp and email. The microscopes do a lot more than what you think. And if you're really not going to use all of that, don't invest in a very big microscope.
Absolutely.
So try to learn all the things. That's
so if you don't invest into Pentero, at least buy S8.
Exactly.
Video.
Yeah.
And the other thing is recording. With a microscope,
exactly. Recording. Yes.
Always record all your surgeries. So it's standard for us. Everything under microscope is recorded, and everything has to be seen by the nurse too. So you have a copy of what you have done in irrespective of, like, it's standard protocol theater that microscope is used, recording is on.
Same, Bala, you said that that you if you're not going to use it too much, you may use a cheaper one. But I beg to differ. The
I didn't mean cheaper one. I don't mean a cheaper one.
Cheaper one, he means don't buy Pentero.
Like don't buy a Pentero.
Yeah,
you don't have an exoscope. Yeah, we have microscopes where the full effect is when you buy an exoscope, when you buy this, that, additional gadgets. It's really not needed unless you're not going to use it. So you can buy a decent one, whatever. That's what I meant.
Yeah. And also, Bala, the current ones, the newer ones don't work when the bulb is finished X amount of hours.
Yeah, true.
Correct.
They don't switch on. So, and most of them have got a stand-up light now. So your xenon phase, you have a argon or argon xenon backup. So they're actually getting foolproof. Yeah, it's like getting into a more complex car.
And it's like as Bala said, iPhones. I think your visual field only microscope pops in any warnings. Which is required. So actually, you really don't need everything is on the screen in modern microscope. That pops in.
Correct. Yes.
So
Mr.
Yeah.
For the new learners, I think you just have to only understand that. Take it step by step, as Satyen was saying. Do simple cases, then go to drill, then do complex stuff. It must be like any other instrument, gadget, or surgical procedure.
Right. So Mr. Karthik is with us from ZEISS. Maybe I would invite him for the valedictory, and we'll close the session thereafter. Mr. Karthik, over to you.
Thank you, sir. This was a wonderful session. Thank you for all your feedbacks. We are all a lot of sharing actually for that matter. And hello. Am I audible by any chance?
Yeah, go ahead.
So I would like to thank everybody for that matter, for your insights and all. It was a very, very good session for the fact that we had a lot of experiences, not just from orthopedic surgeon, but also a point of view from a neurosurgeon coming in terms of the usage of microscope. And this also gives us an opportunity to look at what all can be done in the form of sessions going ahead. Thank you, sir. Thank you for your time. And this was a wonderful session. That's what I can tell, sir.
Neeraj, you want to conclude?
Thank you. Thank you, ZEISS. And thank you, Dr. Neeraj, from one Neeraj to another. Thank you, Ranjith. Thank you, Satyen. Thank you, Dr. Bala. And thank you, Vishal. Thank you, ZEISS, for bringing us this very interesting symposium on microscope use.
No, thank you, OrthoTV, Neeraj and Ashok, without you, such programs are never possible.
Okay, thanks a lot.
Thank you.
Bye-bye.
Thank you, guys. Thank you. Bye-bye.
Thank you all.